Hi, my name is Wa'al Taha, an orthopedic trauma surgeon from Medina, Saudi Arabia. It is my pleasure to be presenting to you this lecture on absolute stability, biomechanics, techniques, and fracture healing. Hopefully, at the end of this lecture, we will be able to define the definition of absolute stability. We should be able to describe how the biological behavior of fractured bone is affected by absolute stability. We will define the indications for selection of absolute stability according to AO principles, and we should be able to explain the techniques for achieving absolute stability. Now, we all know that the intact cortex is a very strong structure and is also characterized by being stiff, and it can only deform by less than about 2%. Once the stiffness is lost, instability occurs and a fracture happens. Fractures tend to heal as long as the bone ends are in proximity, and they heal with callus formation if there is no kind of surgical intervention. This callus is a result of some micromotion that happens at the fracture site that allows the callus to form and to help with the healing of the fracture. However, sometimes this healing may result in a deformity because inadequate reduction. This deformity could be a shortening, could be an angulation, or could be a rotation, or could be a combination of some of these different deformities. In order to avoid these deformities from happening, we very often approach these fractures with open reduction or closed reduction and internal fixation. We maintain the reduction with implants in order to allow for the healing to happen. This also helps with managing pain, and it also helps with the early return of function in these patients. One of the principles is to fix these fractures to allow early return of fractures. The intervention that we do will define what type of stability we have obtained, and that will have an effect on the type of bone healing that will result. How stability affects healing. We know that our internal fixation will alter the biology of the fracture healing. So how this happens? This depends on many factors. This includes the type of the fracture, the type of reduction, the type of stability that is achieved, and the type of implant that we choose. So for instance, if you have someone with a simple fracture, then we can reduce this anatomically, and we could achieve absolute stability in these cases, which would result in a direct bone healing. In contrary to someone who has a complex fracture, we know in this situation anatomical reduction may be difficult or maybe at the expense of compromising the blood supply, so we aim for functional reduction, and in these situations we rely on relative stability. And so in managing fractures, once you have a fracture, an inflammatory response starts, and the first stage of that is the hematoma formation, followed by microvascular ingrowth and granulation tissue formation. Then we have cell differentiation. At this stage, we intervene with our surgery, and we stabilize the bone in one of two methods, either with absolute stability or with relative stability. If we are able to obtain absolute stability, then the bone heals with direct bone healing. If we obtain relative stability, then the bone heals with indirect bone healing. So it's very important to realize that the method of stabilization that we perform will have a direct effect on, or a direct effect on the type of bone healing that will happen. So what's the definition of absolute stability? Now, absolute stability means that there is no kind of micromotion between the fracture ends under normal physiological loads. And we do this by anatomically reducing the fracture and holding it with an implant that is able to achieve a absolute rigid fixation with no micro motion. In order to do this, we need to do an open reduction so that we could reduce the bone ends in an anatomical way. The best method to produce absolute stability is with interfragmentary compression. We'll talk about that in more details in a minute. And once we have this kind of absolute stability, this will lead to direct bone healing. Now, what does direct bone heal meaning? It means that this was formerly called primary bone healing. It means that the ends of the bones have to be in contact to allow for internal osteoinal remodeling. This requires anatomical reduction. There should be no motion between the fragments, and as a result of this, there will be no callus for formation. This is a bone that was fixed with absolute stability, and you could clearly see that there is revascularization across the fracture in the middle there. And this is one of the advantages of absolute stability and direct bone healing. These are some of the methods that can be used to obtain absolute stability. The most common is the lag screw and the axial compression using compressing plates. In some situations, also a buttress plate can be used as a method of absolute stability. So since the lag screw is the most used method to obtain absolute stability, there are some principles for lag screwing that we need to understand. First of all, it is a technique of insertion. It is not a type of screw. We don't have a screw that is called a lag screw, but it is rather the technique that we use that is a lag technique. And because of that, any screw can function as a lag screw as long as these techniques are followed carefully and the principles are maintained. A lag screw produces intrafragmentary compression, and it can produce up to 3,000 newtons of force. So in healthy bone and in thick bone, this can be a very, very strong force across the fracture. The lag screw fixation will result in absolute stability. Now, we said there are some conditions and some principles that you have to follow. So for instance, the Ferris glide hole that the screw needs to go through, this should be bigger than the screw itself to allow for the screw to slide. The threads only hold onto the far cortex. The head of the screw sits on the cortex, and so we have to prepare the cortex with a countersink so that the head can sit on the cortex to help with achieving the compression. And for the best results, the screw should be introduced perpendicular to the fracture line. With lag screw fixation, there are some screws that you don't need to, for instance, do an over-drilling of the Ferris cortex. These are called shaft screws. These are special screws where there are no threads on the proximal part for the screw, and these can be used for intrafragmentary compression. What is important is that you must make sure that all the threads in this type of a screw cross the fracture line in order for compression to happen. Anytime a screw crosses a fracture line and it can provide interfragmentary compression as long as the principles that we talked about have been maintained. Over-drilling of the proximal cortex, the screw should be perpendicular to the fracture, and the screws should only hold into the far cortex. It is very important to avoid displacement of the fracture that the screw is inserted perpendicular to the fracture line. Now, the next method is axial compression with compression plates. This is especially helpful when you have something like a transverse fracture, where it is difficult to put in a compression, a lag screw. So in these situations, compression plates can be used. dynamic compression plate or a low contact dynamic compression plate can produce absolute stability. However, this still requires anatomical reduction, and the axial compression is obtained with the plate. This is something that you would do in your practical, and you will learn more about it. So we insert the first screw into the plate. This is a fixation screw, and then the second one is inserted in an eccentric manner into the plate on the other side of the fracture. And as we advance the screw into the plate, it will create a compression across the fracture site. Nowadays, we also have the locking compression plate, through which we can also obtain the same effect as with the DCP, or the dynamic compression plate. However, the prerequisite here is that you have to use the conventional screws first before the locking screws, and you have to use the dynamic compression hole to obtain the compression before putting any locking screws in. So these two conventional screws have to be put in first, following the same principles that we use for the dynamic compression plate, in order to use a locking compression plate as a device to obtain absolute stability. Finally, let's talk about the clinical indications of absolute stability. Articular fractures are one of the indications, because we want the articular surface to be reduced in an anatomical fashion and to heal without callus formation. Simple diaphyseal fractures, especially in the forearm, can be treated with absolute stability. Some simple type A metaphyseal fractures can be treated with absolute stabilities, and osteotomies should also be treated with absolute stability. So, in short, or in conclusion, absolute stability implies there is no motion between the fracture fragments with normal functional loads. The best method to achieve absolute stability is with intrafragmentary compression. Absolute stability is indicated for articular fractures and simple diaphyseal fractures. Fractures treated with absolute stability can be expected to heal with direct bone healing with no callus formation. Thank you very much, and I hope you have enjoyed this lecture.